Welcome, everybody. Thank you for attending the third segment of our Quality Improvement Research Boot Camp. Before we jump into the topic at hand, I want to mention kind of how we're finishing up this series. After we learn about the IRB and as it relates to QI, we will have a writing workshop. We'll actually have a QI writing seminar as part of boot camp, but that afternoon we'll have a focused quality improvement writing workshop. We will have an expert who will be here from Dartmouth Medical Institute. He's an editor on a number of QI journals, and so if you have QI data that's ready to write up, or even if you don't, this should be a very productive time. So we have a sign-up sheet outside to get more information, so I can follow up with you on that. So today I'm going to introduce our two speakers. We have Dr. Daniel Vasgird and Steve Davis. Dr. Vasgird is the Director of the Office of Research Integrity and Compliance here at West Virginia University. And he's also the Director of our Ethics, Regulatory Knowledge, and Support Core or Program at the WVCTSI. Now, a little bit of background for Dr. Vasgird. His initial training was at University of California. He completed his PhD in social psychology at Syracuse. He returned to University of California and did an NIMH postdoctoral research fellowship. Then he worked overseas as a human service educator and consultant to the federal government. So he's done a lot. He moved to New York after that, and he has a number of positions. He was IRB Chair and Senior Research Scientist with the New York City Department of Health, Associate Professor in the School of Public Health, and Director of the Office of Responsible Conduct of Research at Columbia University, and Associate Professor in the Department of Preventive Medicine and Community Health at State University of New York, Downstate Health Sciences Center. He has written and presented extensively in the areas of research ethics and human research protection, and he is a really nice guy to add to that. And our co-presenter is Steve Davis, and he has been a wonderful supporter of the CTSI. He is Director of the Clinical Research for the Department of Emergency Medicine here at WVU. He is an adjunct associate professor in the School of Medicine and School of Public Health. He graduated from WVU with a degree in social work, received his master's in public administration and in social work as well. And he has been a member of the Institutional Review Board for what seems like to him forever. He has served as chair of this board from 2009 to 2013. So thank you both, and we'll start with Dr. Vasgird.
Thank you very much for the gracious introduction. I'm the appetizer here, and the entree is Stephen, and so that's right. I'm one of those guys who likes to work the room, and he wants me to stand behind the microphone. So when we discussed this, we talked about that it'd probably be best to approach it, give a quick overview of history of human research protections and a couple of things that we've had, issues specifically that we've had here at WVU, and then I'll turn it over quickly to Steve. As always, the dilemma that we all deal with, human dignity, social justice, in an economically and politically imbalanced world. I drew this from the Department of Energy. As a matter of fact, they have this within their human research protections policies. What I like to think of, that the heavier scale, the one that has the heavier side on it, I mean, you could think of research institutions, the researchers themselves, the funding agencies, federal government. All of that is on that one side, and on the lighter side is human research participants and all of the data that we collect, things that need to have themselves very special consideration in the move, or the dynamic that we all call research, that we call science. And so that's what we're supposed to do in IRB world, human research protections world. I'm just going to cover a few things. Some of you have heard me going through some of these things in the past, but this is an abbreviated version just to give you an idea about where we've come from. Science formally has been around for about 300 years. Human research has been going on, much longer even than that. It's interesting, though, that only until the middle of the last century did we start to have anything formal. You recognize the word Nuremberg right there. This is an example. I could have pulled up thousands of photos, but this was at Dachau, and that's an ice tank there. Those white things are ice blocks, and that's a prisoner at the concentration camp. What I read in the book was that he expired about 10 minutes after this photo. He's tied up. That's supposed to be a protective suit, and they were doing this for trying to do something that would help their pilots going down in the North Sea. But life was just considered to be expendable in what they called medical experimentation. These people, there was a special segment of the Nuremberg trial in which medical physicians, medical researchers went on trial. That's this particular section here, and that led to the Nuremberg Code. The code, again, 1947, it's primarily remembered for the first sentence, and this is the first formalized statement that we have in terms of research protection. Voluntary consent of the human subject is absolutely essential. And that's the foundation point for all of us. Here in America, Nuremberg has impact. American researchers thought something, but there was pushback. It was never formalized here in the United States. There was never any regulations that were set up behind it. That didn't come until about 30 years later. American scientific community pushed back, said that we would never have the Nuremberg Principles really applied to people, those bad Nazis that were doing it. We would never allow anything like that to happen. So there was no real set rule that one had to follow, but we have one after another. Scandals keep happening from the late 40s. Everything from we find radiation scandals related to all of the atomic testing and a whole range of other things that are going on. This is one of the more notorious ones. Willowbrook State School. When I lived in New York City, we lived on Staten Island. Willowbrook was about a mile from where I lived. It's now the College of Staten Island in the CUNY system. But and it had been around for a long time, and it took very, very, very challenging children into admission, and would it would take and support them, and but for 7 years, from 1956 to 63, a child was only allowed to come in if the parents accepted, if the parents signed off, and one of the conditions was, or a major condition was, that the child would be infected with hepatitis A. And then they would go on to, well, this was discovered. It became a huge scandal in the United States. Editors, people are writing pushback all over the place from it. One of the things that came out of that was the Declaration of Helsinki in 1967. This is the World Medical Association meeting. It's been going on, but Helsinki, as a matter of fact, was just revised again recently in the last few months. But they wanted more specific rules than Nuremberg was giving, and so the American Medical Association, by the way, is one member of the WMA. They talked about consent in writing, previous work, written plan, IRBs, caution if there's a dependent relationship with the researcher, and in the United States, at least, this was implemented and legislated. Best proven care has to be received. Then another scandal comes about, Tuskegee. Everyone heard about that. There were more that I could refer to, but Tuskegee is uncovered in 1972. It had been going on for 40 years. It gets finally, and there were a number of times that they attempted to publish it in the New York Times. There was pushback from the Times, and it was never published. It was finally broken open in 1972 in a small newspaper in Washington, D.C. The next day, the New York Times puts it on its front page, and it explodes. Ted Kennedy, new senator at the time, takes this up as his mantle and starts pushing for it. And out of that, we end up with the National Research Act of 1974. This is, again, about 35 or so years ago, and this is why we're all gathered here in this room. This is where the regulations come from. The person who was there was another incident that happened in 2011 related to this person, the second person from the left there, Dr. Cutler, who ran the Tuskegee trial, or the study, for about the last 20 or 30 years. He had also gone on to Guatemala, and it was even a step further than the Tuskegee incident. There was a researcher that was looking at the Tuskegee research about 3 years ago. She came across Guatemala. Guatemala keeps popping up. Cutler keeps popping up. And she finds out that Cutler had gone down there. Now remember, at Tuskegee, they took men who had already been infected with syphilis. They went to Cutler went to Guatemala in the 1940s as a PHS officer and infected people down in Guatemala. That's discovered, and about a year ago, 2 years ago, President Obama gives a check for $125 million to the president of Guatemala with an apology, and that pushes us on even further. So, National Research Act requires informed consent, requires review and monitoring of research by an IRB, and creates a national commission to look over these things. In 1979, we have the Belmont Principles, which are the guiding ethical principles that an IRB uses when you're supposed to be figuring out something, or when you are. The Belmont Principles they're really very good. They're only, and the Belmont statement or the report is only about 8 pages long. You could sit down and read it in a very short period of time. This is very important to understand too. In the National Research Act, the way that it was put, the 45 CFR 46, Title 45, Code of Federal Regulations, Part 46, is only about 20 pages long. There was a vociferous, a very passionate debate back in 1974. Should we have something just kind of parallel to what we have? Should we have something similar to HIPAA, or should we have something more moderate and that which would decentralize decision making? They decided on the latter. So that's where the importance of institutional review boards. HIPAA, for instance, and a friend of mine is a HIPAA officer, copied out the HIPAA regulations, and they're about 2 Manhattan phone books back to back. I mean, they're just monstrous. 20 pages for the 45 CFR 46. Marked contrast. The committee that puts it, the commission that puts it together, says the major decisions that should be made using the Belmont Principles, but those decisions should be made at the grassroots, where the research is taking place, and that's why the IRBs are so pivotal in this role. We do not want to try to foresee every single situation that's going to take place. So they didn't, they defer. Human research protections, then. Here, at any human, and this is an important statement to pass on to you and your staff and all who work on research at WVU. Any human subjects research conducted by or under the auspices of any faculty, student, or staff using our facilities or data, or accessing WVU staff. If you send data off to somebody at Purdue or whatever, you've still got to go through the IRB if it's human research. If it accesses our staff, patients, you've got to go through the IRB. If you have questions, just make sure you come to us. Come to the office. Flexibility is a principle that I've carried with me as an IRB chair and director for many, many years. And it means something like if it's a bubblegum taste test, then you treat it with with very minor risk. And that's something we are doing here at WVU, by the way. And but if you're dealing with an HIV vaccine phase 1 trial, you got to ratchet it up. I say that because that's something that we have had, that I dealt with in the past. Then you have to take it very seriously, and you give the time and attention to it. We have 4 levels of review. Not human subjects research, which means it falls outside of the federal regulations. And for instance, a lot of people that for a thing that would be NHSR might be parade or crowd research that's done. And there are many anthropologists or people that deal with those sorts of things. Also people that deal with crowd movements and stuff. Doing that kind of research with people would be NHSR. It doesn't fit the definition. 2 definitions it has to fit. Research and human subjects. For generally human subjects, it means a living being, and that you're collecting data about, and research generally generalizable and systematic are the 2 key words usually for that. The 3 that fall under the federal regulations are exempt, expedited, and full board. Exempt is a misnomer to a degree, because exempt means that it's exempt from IRB, Institutional Review Board member review. It means that it can be reviewed and approved. It's very low risk. It can be reviewed and approved by an IRB administrator, somebody in our office. We have 3 people who can do that in our office, and Lilo, Barb White, and Jonathan Young. Expedited means, and full board means it has to go to the board. It's higher risk. It's going to have to go. Expedited, though, means it can go to 1 board member, and full board means what it says. It has to go to full board. Our turnarounds on NHSR, they're usually 1 to 2 days. Exempt are about 4 or 5 days if you have to get some more information or something. Expedited is usually going to run a couple of weeks. And a full board, you have to allow that the time that it's going to have to be reviewed and go back and forth and those sorts of things. So it's going to be at least 2 or 3 weeks to do a full board or a month review. Authority of the IRB, require review, approve, disapprove, modify, conduct continuing review. Must be done at least once a year, but the IRB can show, if somebody calls us, and that happens sometimes in our office, the IRB will designate a small committee, or an IRB member will be delegated to go and visit the person at their site, if it's at the research site. And that can be done at any time. It's just if it happens, then there they are, and deal with it. It's usually not going to be something that's serious. It's just going to want to verify an informed consent or the like. We do QIP, Quality Improvement Program. We have QIP, what we call QIP visits that happen intermittently. Do about 4 or 5 of those a month, and those are in-house things. We usually Lilo, Jonathan go as a team, and or Barb, and visit, and they'll just go through the files, give the report back to the PI, and it doesn't go anywhere. It will be, we'll tell them for their sake and for their benefit. We have to do this for accreditation, but when you hear that a quick visit is happening, most people now realize that there's no harm in having a QIP. It can only help. If we find some things that are wrong, significant, this is for your benefit. Get it, be able to improve, and then to move on. Observe, verify changes, suspend, or terminate approval. Rarely, we have suspensions, but terminations are rare. I think we've had 2 since I've been here at WVU, and I've probably had a half dozen in 25 years I've been working in this field. The IRB does everything it can. The person would really have to do an end around or something egregious to get themselves terminated. So it very, very rarely does that happen. Keywords. When I became an IRB chair, and I was put into I was a researcher, and my boss, at the time, by the way, my boss was Margaret Homburg, the head of the FDA now, and she told me, she was giving me a promotion, and she said, well, one more thing, I'd like you to take over the IRB, and she said it shouldn't take you in about 10 or 15 minutes a week to do that, and and one thing leads to another, and here's where I am now. But it was when I would call OHRP that first couple of years to get advice, these are the 2 words that I would get back from the federal government at almost 99% of the time. Reasonable expectations. Remember now, 45 CFR 46 and how it is decentralized. What would a reasonable person expect in this particular situation? So when I was looking for guidance. So that's what we're here for today. Reasonable expectations. Now, before I turn it over to Steve, let me just these are a couple of things that have happened here at WVU, and I just wanted you to note them so you can pass them on, things that we found from doing our QIPs and the like. Keep your protocols, your consents up to date regarding who's involved in the study and the research methodology. If a person leaves or is added to the study, notify the IRB through an amendment and update the protocol to consent right away. If a person's consenting, they need to be on the protocol and on the consent form. This becomes a problem when you've got residents rotating every 3 to 6 months or whatever through a program, and they're being delegated to take over a lot of the responsibility for a particular study. So that is an issue, but you've got, and it doesn't, the amendment process that we have is one that's, it's just a couple of sentences, send it to us by email, we'll plug it in with no hassles and try to make it it is very painless, as a matter of fact. Other than signatures, don't write on the consent form. We had some issues with that. When you're doing a quick review or you're doing something in clinic, people can make notes in the margins and stuff. You can't do that with the informed consent, nor can you cross out or white out. I mean, that should go. It's a legal document, so you can't do that, and it'll invalidate the ICF. Confidentiality, privacy procedures, separate consent from the data collection form. Don't put the subject's name on the data collection form. Protocol termination by the board, I just talked about that. You must always do what the protocol says you will do, and the amendment and continuing review process are the opportunities to make changes. Amendments are not difficult, let me emphasize that to a great degree. So, that's my introduction. I now turn it over to the lead guy, you might say so, and let him go to the meat of the matter. Thanks, Steve.
Thank you very much, Dr. Vasgird. I think I've been called a lot of things over the years, but I think this is the first time I've been referred to as a main course, and so hopefully I will not disappoint. So here's the issue. Dr. Vasgird, I'm being told to stand there. I like to walk around as well. Dr. Vasgird provided a very nice historical overview of the underpinnings behind the emergence of IRBs. As well as the authority of IRBs and what we really do as an IRB, which is to protect human subjects and to maximize the principles of autonomy, beneficence, and justice. Okay, here's the dilemma, and I think that's why a lot of you are here, other than just for the food. Okay, there are many QI activities that share characteristics of research. Okay, many QI activities involve measurement. You're collecting data. You're usually doing some type of before and after comparison when an intervention has been implemented to improve some aspect of the institution. Sometimes you may even use some statistical techniques to look at whether or not before and after there's been a change in what you have implemented to try to improve the institution. So that really does beg the question, how in the world do we know whether or not what we're doing is research and thus subject to review and approval by the IRB and the points to keep in mind, or is it truly QI? And it's something that I think it's fair to say we will continue to wrestle with, but this is certainly a good starting point for us. So how do we determine then if IRB review is needed? Well, we first start with 45 CFR 46, because that is in fact our blueprint for IRBs. And it is brief, which is nice, although it is recommended reading at times if Ambien isn't working for you. But it is very important. Okay. So there's two things we have to do in order. There's two main things we have to determine when we're wrestling with this question. Is this QI or is it research? Okay. One is, does the activity involve research? And I'm actually going to give you the definition. There's actually a definition of what research is in 45 CFR 46 momentarily. Okay. Then the other thing that we have to do is, if we've decided, yes, this is research, then we have to decide, does it involve human subjects? Now, you would think that is self-evident, but when I show you the definition of what it means to involve human subjects, it's not as self-evident as you may think. Okay. But those two things have to be considered when we're answering this question. Is it research versus is it QI? Okay, so let's go to the definition from 45 CFR 46 of what is considered research. Okay, I'm not going to read the whole thing to you, but I bolded some terms there. Research is a systematic investigation. This is where we talk about perhaps employing techniques like randomization, control groups, some type of systematic look or activity that most importantly is designed to generate knowledge that could be generalizable. Okay, so it's designed to create or contribute to generalizable knowledge. Okay, what, as you can see in this definition, makes it difficult is it says right there are some demonstration and service programs that may include research activities. So again, we go back to there are many elements of QI that share characteristics of research. So that's the first thing to consider. Is this research? And what we're going to do is we're going to go over some examples and have some back and forth, because I think this is probably the best way to tackle this type of complex issue, and hopefully we'll also have some time left over to really have a back and forth about some questions you might have as well. And I think the good news is I'm back in here barricaded, so at least things start coming my way, duck or anything else. So the other thing is that let's say you've decided, okay, this is a research activity. Okay. Then the next thing you have to do is you have to say, does it involve research with human subjects? Okay. That has two parts to it. If you're conducting research, it involves human subjects if you're interacting with human subjects and you collect data via that intervention or interaction. But then the other piece is you may be looking at existing data that involves identifiers, or you may be handling identifiable private information when you're not actually interacting with the human subject. Okay, so those are two things to keep in mind. Here's what I think might be helpful as we start to think of a framework, because we've given the definitions and we're still like, and I'm sure many of you are sitting out there going, well, but what about this activity I'm doing that I'm thinking is QI? How in the world do I use the definitions of research and human subjects in 45 CFR 46 to truly make a comparison? In our review of the literature and discussions with Dr. Barreto, Dr. Vasgird, and other folks, there's three potential, and I use the word potential, lines of demarcation that might help guide whether or not something is QI versus research. Okay? The first one, and I believe that in some manner these are on some cards we have that you can carry around with you that we've provided, and thank you very much for putting those together. We need to look at whether or not what you're doing is implementing an evidence-based best practice. Okay? That's a very important line of demarcation, because if you're implementing something that is evidence-based, that means that the research has already been completed to provide the evidence. Okay, so the research has been completed to provide the evidence that this is a best practice. Therefore, someone else has created the generalizable knowledge. Okay, that's one way of looking at it. Another thing would be if there is no funding, it may not be research. Okay, I'm not going to use definitive statements because it's a complex issue, but more often than not, if you have something that's funded, the agency typically will require you to seek IRB review and approval, which may indicate more often than not that this is intended to be a research activity creating generalizable knowledge. Okay? And then the third one, if results are directed at the organization, the focus of what you are doing is on improving the organization. Okay? It's not on improving society or many institutions, it's on improving your organization. Okay? So as we started to think about this, these are the three themes that emerged that might be a potential guide as to whether or not what you're doing is research versus QI. How about we take a look at some examples? All right. Example 1. Hospital X, and this actually I think is one of our QI goals for the hospital currently. Hospital X is implementing an evidence-based best practice to reduce rate of C. diff infections. Okay? Rate of C. diff infections are examined before and after an intervention. Results are going to be shared with hospital administration. There's no funding of which we are aware for this activity. What do you think? QI or research? Why? I'm hearing, anybody want to say research? I'm hearing mostly QI. Okay, why? He said this would be interactive. It's lunch hour. I'm sorry? Using a best practice. Exactly. So the best practice exists. Okay. So you're using a best practice. I'm sorry? The results are, so the focus is on the organization, right? Excellent. So implementation of a best practice. The research has already been done to establish that this is a best practice. Okay? So you're not doing something aimed at creating generalizable knowledge. Okay? And, as you said, the focus is on the institution. Okay, you're reporting back to hospital administration. The focus is on improving the institution. Okay, and the project is not funded by a grant. That's something, that's the easy one. Typically, if it's funded, they'll tell you, go talk to the IRB. Okay, if only it were that easy. All right, let's look at another one. Sorry, yep. They are, and right. So the question is, what happens if a resident is doing this activity and they want to present it at a meeting and they want to publish? I will say preview of coming attractions. I'm going to deal with the publication issue because this is the hardest thing to deal with. And if you just give me a couple minutes, I promise you I have a slide because this is where we start to wrestle. What if you want to publish? What if you present? So it's an excellent question, and I'm going to come back to it. Okay? Let's look at a couple more examples. An internal medicine physician is interested in whether or not using smartphones, Okay, and other technology, maybe iPads, Android tablets, otherwise, will help his or her diabetic patients monitor their glucose levels better and ultimately improve patient outcomes. If there's money, this person would like to seek some funds to help promote and support data collection, perhaps buy the tablets, smartphones. What do you think, QI or research? Why research? I made these too easy. You guys are all experts. Why research? New knowledge. Okay, so this isn't probably a best practice yet. It may be once we do the research to give the evidence. Okay, and so in that case, you are probably looking to create knowledge that's generalizable. Okay, to other clinics, to other patient settings. Okay, and you're seeking funding, and so that's probably in the form of a grant where they're going to want to see some type of IRB review and approval. Okay, third one. Clinician is interested in whether or not daily application of a topical antimicrobial agent at the tracheostomy site significantly reduces hospital-acquired pneumonia. Clinician would like to examine the success of this activity by randomizing patients to either a daily application group or routine no application group and examine outcomes. Research? Anybody want to say QI? See, you guys are all experts. This is great. Why would you say most likely research? Again, I'm not using definitive statements. Most likely research. Why? Ooh, I heard randomization. That's a good one, right? That's kind of more of a systematic investigation at that point, isn't it? You got it right there. It's not a best practice yet, to my knowledge. Okay, I was looking for some good examples to come up with. But if it's not a best practice or evidence-based, that's a line of demarcation, because then you're probably doing something because you want to create generalizable results. Okay? And, as somebody said over there, it employs a formal element of research design. Okay, and so that's where we go back to 45 CFR 46 in the definitions of a systematic investigation. And oftentimes when you start talking about randomizing, case control, control group, things of that nature, you're probably getting more into the research realm than the QI realm, although nothing's cut and dry with this. Okay, final example, and then we'll go back to the publication piece, which is very important. Okay? Clinician wants to analyze de-identified medical records to test a number of hypotheses and publish the results. What do you think? I'm hearing research. Anybody say QI? Possibly? Okay. Thinking research. Why would you think research? Hypotheses? See, I made these a little too easy, but that's okay. All right. Okay. You're using formal methods to test hypotheses. Okay. Here's where I'm going to duck if I need to, though. There's an asterisk to this, because I don't want Dan to come up here and, you know, slap me or anything else. Okay. Why would I say no IRB review is required? So we now go back to 45 CFR 46, the second half, you know, of the definition of human subjects. The second half is you may not be interacting with them, but you're using identifiable data. So if you're not using identifiable data, then OHRP, their guidance has suggested this is not human subjects research. Yes?
So one of the tripping points is actually your first example, where we're...
Right, right. And so in that case, I think it becomes helpful then to look at why are you doing the project. In that case, it might be focused on the institution. And importantly, you know, are you, you know, that's a measurement. Are you collecting data to evaluate the impact of a best practice or not? Yeah.
Let me just, a qualifier here is too, if the physician is doing the de-identifying, all bets are off. If
Right.
you're going to sit down and do it, it's got to be truly de-identified, perhaps by the data repository or whoever the person is in charge of that, who's in charge of medical records, and usually they will have a process for that. But if the physician wants to sit down and de-identify and then do the analysis, well, they have access to identified data.
Right, right. And again, that's a good question, because these are very complex considerations, which is why I'm not going to put up there most likely. I'm using most likely, probably, because it all depends on the details. Okay, now here's the asterisk, okay? OHRP, including WVU, okay, highly recommend that you still check with the Office of Research Integrity and Compliance. It's highly recommended that you just check, and this doesn't, I mean, you can create a formal NHSR request within the KC system, okay? We can review that, and if we agree with it, then we'll give you, yeah, we agree, this is not human subjects research letter. It takes about a day, if that. It takes about 10 minutes to put in the system, okay? However, you could also email one of us, telephone, we can give you something. We just recommend that you check, because the worst thing in the world is that you're doing something that wasn't NHSR, and then now it's after the fact.
Right.
And
you can't believe how many editors will say, did you run it through? Who made
Right.
the determination?
right.
And these days, many editors and journals will ask that. Well, if it is NHSR, who made that determination? So you want to have that, and if it doesn't take but a few minutes to do it, you want to have that two-sentence email that says that the IRB has said that this is NHSR.
Right.
Tuck it away, and now you're covered.
So this is a very nice segue into the publication question, because, or the publication and or presentation, because it comes up all the time. Okay, and there are a lot of journal editors that will say, well, where's your IRB if you want to publish QI results? Okay. The intent to publish in and of itself does not mean that an activity is automatically research. Okay, that's an important point. Now, I see you struggling, because I struggle with it as well. It can become gray, because at what point, you know, does the intent to publish equate with the intent to generalize? And I think that's where it gets back into, are you implementing a best practice? Are the results focused on the organization, etc.? Okay, or if you're using de-identified data, did you get your formal NHSR designation so you can say to the journal, well, we did check with the IRB. Okay, so that gets back to the question, if a resident is doing a QI project and want to publish it, can they? Okay, I can tell you this is an emerging issue for us. We are forming a committee to really look, because we know that QI more and more is becoming a very important activity. Most residencies now, our previous discussion from Dr. Shaver and Dr. Beretta talked about how, you know, more and more QI is at the forefront. And at times you may want to publish. You may want to say, okay, we were implementing a best practice at WVU and we'd like to share that, but we didn't go through the IRB. Well, I think we'd say a couple things about it. It can't hurt to check beforehand, and we may say, yeah, we think it's QI, but the other thing is where you may get tripped up sometimes is if you then go to publish and they say, did you check with your IRB? Well, if you can at least say we checked, then that's better than saying, well, no, we didn't. We just kind of, you know, on our own determined, yeah, this is QI, we're good. But I guess what I'm saying is that you can still publish without IRB approval if it is determined that this is truly a QI activity. Some of the other documents that we've reviewed, how other universities and institutions handle this, is they have verbiage that they require to be, you know, put into those types of manuscripts or posters, something along the lines of, you know, this was solely intended for a QI project, and as such was not reviewed by our IRB. But the take-home message is, okay, you don't necessarily have to have an IRB to publish, but it can't hurt to check so that you don't get caught on the back end, you know, when you want your resident or, you know, to go publish and present.
Is there a mechanism? So let's say Dr. Koo, as infection control guru of our hospital, is randomizing the odd number of beds in the hospitals to get the poison gas for the C. diff and the even number of beds to get the housekeeping alcohol wiped down. And it's really cool, and she wants to publish, and she wants IRB approval, but it's already been done. So is there like past tense in IRB approval?
That's the nightmare calls that we have that come in, okay? Because as you can see, my final point there, that's very problematic. We get these calls that come in and say, I know, we get these calls. I try to anticipate everything that would come up. We get these calls that come in like, well, I did this, and now I want to publish, and the journal wants me to get IRB approval. Can you help me? To which we, one, see if it's happy hour anywhere, and then two, try to figure out, well, I mean, it's one of those things because of the great flexibility in 45 CFR 46, you can't say with certainty yes or no. But more often than not, and Dr. Vasgird, if you'd like to, chime in here, that's fine. It's hard to go back. It's very, very hard, because we then have to consider if this was a research activity, did you maximize autonomy, beneficence, and justice, and all the things we were supposed to do. And so then if you didn't, then it's like, well, that may not be approvable. So
I always strongly suggest, and just like Steve was saying, that even if it is a QI project, still run it by, get the email message from the IRB, going to be able to show it to the editor or to the review committee for whatever journal or something you're publishing at, and to show that you made a due diligence effort to check on this.
Right.
It's just sometimes, and it's not totally impossible, but sometimes if it's with a small sample, you can go back in time and get yourself and get consent from people. If it's a 20-person sample, you can go back and say, can we?
Right. So we have to look at
yeah,
all of those things.
If we want to, and that's oftentimes done.
Yeah, but it's just easier up front. Dr. Duckerman.
Challenge you gently on that with Ashley, because I was in the Navy. One of my jobs was environmental infection control. I passed with those guys who
Right.
EPMUs around the world.
Right.
And they were required to randomize quality assurance. Infection control nurses randomize
Right.
quality assurance all the time to make sure the processes and procedures are good. And then if they discover something good that they didn't anticipate, then you're saying you might not be able to publish, but they're required. It's shut the hospital if you don't do the things that you're required to do.
Right.
So I think that one pushes the envelope a little bit in the wrong direction.
Right. Well, I think what's important is, we didn't say you couldn't. And I think this is, an emerging issue even for us. I mean, I think it's very fair to say our committee has felt this beneficial to us as well, because we see these things, and nationally, we're not the only IRB or university that struggles with these things at all. And so I think again the important point is to look at how can we, well, from an IRB perspective, first and foremost make sure that we are protecting human subjects if it's research, okay, and doing what we need to do, but also, yes.
Yeah, let me just add, just remember, that was the reason that we put the history in here. Moving back, it's an important element, respect for persons. The IRB members, the committee, as a matter of fact, when the dozen or so people, and that's most committees, are like usually about a dozen, those individuals, when they walk into that room or when they do an IRB activity, they are supposed to leave all affiliation with the institution or whatever. They walk into that room and their only job is to be an advocate for human subjects. They're asked to be there hopefully because of their wisdom, their knowledge base, their commitment to ethical responsibility, that sort of thing. But that respect for others, reasonable expectations is important here, because when we're discussing these things, you've got to, what I was told by the Fed many, many times when I was first starting out, if it was your son or your daughter, your mother, father, brother participating in this project, would you be okay with it? Would you be okay sharing this information? If somebody knew that this information was being utilized for such and such purpose, do you think they would be okay with it? Would you be okay with it? So it's a really important question. That's why that flexibility component is there. But you're always supposed to take the side, and we're under, right now, this is not new. The NSA controversies and scandals that are taking place right now over the last couple of years have just exacerbated all of this. So people using your data, and so it's a really important question. So,
yeah,
how do you want it to be used?
Right, and I think just to end there, so that we have time for some discussion. The flexibility component. A lot of what usually scares is probably not the best term, but potential researchers or investigators with an activity being deemed as QI or as research rather than QI is when you get into the consenting process. And oftentimes you start thinking, well, how in the world can I get a signed consent form from many people, depending on the sample size, and other logistical considerations. Okay, and this is to point out again, 45 CFR 46 has great flexibility built into it, so that even if an activity is deemed research, okay, we've got some flexibility to deal with the logistics. It's a case-by-case basis. You know, we don't just say, oh, sure, you know, don't consent at all. We would never do that. We don't often, you know, automatically say you don't have to get a signature. But you can see there on the screen, we have a lot of flexibility that we can consider if an activity now crosses over into research. Dr. Barreto, who could not make it today, you know, has a very important example that he often gives where you can be doing QI. You can be implementing a best practice focused at the institution. In the course of that QI, you may develop a research question. You may say, well, you know, if I omitted this segment of the guideline or the best practice, I think it might have the same outcomes, or I think there might even be better outcomes because I disagree with it. Now you're getting into a research question, because now you want to say, let me test this and see if this makes a difference. So sometimes a QI activity can turn into research, and I think that's the other thing to keep in mind. So, you know, the take-home points, flexibility is huge, reasonable expectations, which Dr. Vasgird talked about, and it is better safe than sorry. I mean, this is a growing effort on our part, okay? You know, we would like to make ourselves available so that we can do two things. One, promote QI, because it's important, both among the residents and the institution, okay? And also facilitate those QI activities that may actually become research or turn into research. And we can do both. But this is the starting point. This is the start of the discussion, which is why we had this series. Okay, questions? Yes, sorry. Sorry. I mean,
are you violating HIPAA even though you're not doing research, you're doing QI? I mean, I guess that's the third arm of this.
Right. Well, obviously we don't have time to get into the specifics of HIPAA given the length of it, but I mean, you know, HIPAA in and of itself would be, in that case, you know, the question would be, if it's not research, do you have a purpose for accessing that information, as you know? I mean, that's in general, and that's an oversimplification. What the hospital typically looks at, you know, do you have a reason to be in there? And the reason might be, in your case, that you're collecting data to see is an intervention working or a best practice working, which sounds like it may be QI. Thoughts? I saw another, actually right there.
So let's say you want to publish
Right, well technically if it's QI, then the whole research considerations wouldn't apply. If you want to publish it, and this is where we talked about earlier, that it's easier if you just check ahead of time and you can have an email or something that says, we've determined that this is QI. Okay.
And the triaging process, if it goes NHSR, you file it within the system. Again, it takes just a few minutes to do that.
Mm-hmm.
Then it's going to be looked at. The IRB office is going to determine if it truly is NHSR.
Yeah.
And you're covered.
Yeah.
So better to start there.
You could do that, right.
Yeah, because if it is a higher level, then it's going to be bucked up. So
Yeah, you could do that.
that's
I
one of
mean,
the advantages of going through the system.
Yes.
Suppose you are bringing a new test and we are validating that test. And we use all the de-identified patient from the laboratory. And often it can be published in a clinical type journal. That require IRB approval. It's completely de-identified.
Mhm.
We are validating it in the lab.
mean-
But often it can be presented in a clinical.
So typically what we tell people is that the key word there is de-identified.
Yeah.
Okay? And if, you know, all of the data which you're using, if it's truly de-identified, which means stripped of all 18 identifiers, you know, the federal government has a very strict definition of that, okay, then that would qualify for a not human subjects research designation. And that would be very easy, again, just to check quickly with the office and get some type of determination, so that when the journal editor says, where's your IRB, you can say, well, we discussed it with them, as determined to be not human subjects research. Do I, yeah, at the site, yes. We have a question at the site. one of our external sites? Charleston?
Hi, I have a question about waiver of consent. We have an investigator who's attempting to put together a protocol to collect tau proteins and correlate it with TBI. He was wondering about waiving the consent because he felt that these patients wouldn't be able to properly consent. What are your thoughts on that?
So 45 CFR 46 gives 4 specific criteria that must be met for an IRB to consider totally waiving consent. Okay, it can be done. I can tell you it is very rare. Okay, I know that when I was chair, we did it one time because one of the things in the first line of demarcation and the first one listed of the 4 criteria is it has to be minimal risk research. Okay, and if it's not, then you get into other situations where you may have to look at is there a legally authorized representative or something else that could be done. Obviously, it always depends on specifics, but you know, if you can meet the 4 criteria, there is a mechanism for potentially waiving consent. There's other things that get built into it that, you know, if a patient then, you know, reaches a point to where they wake up or have capacity, that you should inform them what happened, you know, give them the opportunity to withdraw their data. Many things we can do to maximize autonomy. Do I see other hands? Yes, sir.
The question I have is, who has oversight when it comes to best practices? The best practices are moving time.
Yep. I think that's a very good question, and I do. You know, and I think that's something we wrestle with. You know, I think that's something probably for the QI committee to flesh out. I mean, are we talking about published guidelines like the American Heart Association? But yeah, which is again, I think the whole better safe than sorry. Check.
Can you elaborate a little bit on what we talked about doing with this committee so that people have an
Yeah,
idea?
so I've talked about this committee. I mean, we are forming a committee at WVU to really look at QI in detail, in specific the human subject issues or IRB issues related to QI, because we know that it is increasing in importance, and it is something, as I mentioned, that all institutions wrestle with. And so we want to get a committee of members together, you know, clinicians, Greg Barretto, members of the IRB, otherwise, that can really perhaps tackle things. What do we mean by best practices? Okay, because quite frankly, this is a start for us as well. I mean, as QI nationally, with, you know, compensation now more and more being tied to QI, with the federal government I mean, this is an emerging issue for all of us, which is why we are forming the committee to tackle these issues.
Greg had a question that he sent. I have one that I don't think was quite covered. It's just a detail that this is from Greg Barretto. If I need to go through the IRB for my project, do I need to get all of my staff involved that were involved in the QI project city trained and go through that process?
If it's QI or if it's research?
He said that if it ends up going through the IRB.
Well, as always, the details matter. Okay. OHRP has guidance for, you know, on their website for at what point, you know, is someone considered to be sufficiently consenting that they would then require training. So what we say here at WVU is that if we believe that you are sufficiently involved in the consent process, you're responsible for explaining the study, the risks, the benefits, you know, that type of detail, then you need city training, you know, which is our human research ethics training. Okay. If you're not, and that's where the guidance can come, like just, you know, merely calling attention to a flyer, okay, inviting somebody to a research project, you may not need the city training. That's really the line of demarcation, is how involved are you in informed consent process.
So call Jonathan or just ask or call.
Yeah, you can call me, call Jonathan, call Dan.
Call Dan. Yeah.
You know, is it possible, and we see this in community-based research now, which is, you know, emerging, the practice-based research network that Dr. King, I know he was here, talked with the IRB about. You know, is it a situation where every single person, you know, 200 people are going to have city training? Maybe not. But the people that are intimately involved with the consent discussion and process, definitely. I know we're running out of time, so if you would like to chat more about this, I think my contact information is on the card. Dr. Vasgard's information is there. Appreciate everything. It's just a start. Thank you.
Thank you.